Chapter 37. Chapter 37 covers the emergencies for patients with special challenges. Basically, the majority of this chapter is covering those that are probably in long-term care, chronic home care, those sorts of things. Not that these people are not functional, but there are a large number of the issues touched on in this chapter that are generally lifetime illnesses. Can have very degenerative issues where they'll start maybe doing very well and then end up bed confined or even dying. So, but this is a difference between modern day medicine of even 3 or 4 decades ago, where many of these people would have been institutionalized for a lifetime. Many of these people are able to have a quality of life at home now. So it is an advance in science, but it just changes the focus where when EMTs were even thought of nearly 50 years ago, this was not even a consideration. So this is the last chapter in this section, and this is the last section that is really devoted to patient care. The final section that we get into is the operations section, and the operations section covers a lot of things like that are ancillary to doing calls, such as maybe driving and whatnot. So we'll get to that soon enough. So let's finish up chapter 37. Obviously, you have your objectives listed in your text. There's just a few of them for this chapter, and they are listed on 949. There's a multimedia slide on autism. Autism is, obviously a huge sliver of the population. I guess in the grand scheme of things, it's probably not, but we do hear a lot about autism, and so it would be very beneficial to just stop and take a look at that video. The core concepts that we'll cover in this chapter include a variety of challenges that may be faced by patients with special needs, the types of disabilities and challenges these patients may have, special aspects of pre-hospital care for the patient with special needs. We'll touch on some congenital and acquired diseases and conditions, as well as some advanced devices that patients may have at home, and then talk a bit about abuse and neglect. All right, so disability. Disability is a condition interfering with the ability to engage in activities of daily living. Now, in a politically correct society, it's probably not the best way to put that. However, in a realistic standpoint and from the standpoint of an emergent setting, this is probably the best way to put it. So there can be a number of different types of disabilities, whether those are traumatic injuries or medical conditions, or maybe they're even developmental. Cerebral palsy, Down syndrome, those can be developmental disabilities. Some forms of cerebral palsy really don't have a lot of effect on the daily cognitive functions, but they may have more effect on the physical function of the person. So some of those medical and traumatic injuries they talk about: multiple sclerosis, Parkinson's disease, strokes, trauma, spinal cord injuries and whatnot, can all lead to long-term, if not permanent, conditions. We also touch on terminal illnesses. So there are a number of terminal illnesses that we run into, and it seems like the majority of them that we can think about offhand tend to be cancer-related. However, there are many people who go to a service called hospice, and hospice is basically dying with dignity, but they go into hospice services for heart failure, kidney failure, and then other progressive diseases such as Huntington's disease, Lou Gehrig's disease, COPD. Some people will end up, there'll be people who have other illnesses such as AIDS who could end up in hospice care. So while we think cancer most of the time, it certainly can be a lot. A lot of people with terminal illness do have certain technological pieces of equipment around to help sustain their life for a period of time, but in more cases to make it more comfortable. Once a person enters hospice care, the shift really shifts, or I mean the focus really shifts to comfort. Not that comfort isn't important in all illnesses and injuries, but the hospice patient is really trying to live out the rest of their days, which are probably shortly numbered, but trying to live out the rest of their days with some comfort and be surrounded hopefully by some family and friends and whatnot to to die peacefully. Many of these people will also have an advanced directive. So if we have people with the advanced directives, we need to kind of have some familiarity with what different types of forms we may have in our local community. Those that are serving in Iowa will have, there is a recommended statewide do not resuscitate form. It is not mandated, but that's helpful to EMS. It really becomes a big issue when we are in systems that choose to just do whatever they want and scribble something on a napkin, basically. It's more than that, but it seems like that. Says, oh yeah, don't do any CPR on them, calls it good. So knowing what's available in our area, something that's coming up, probably becoming more and more popular all the time, something called a POLST, P-O-L-S-T form. And this is a physician's order for life-sustaining treatment, which helps direct us to say, okay, well, should we or should we not do anything for this person? And the POLST form may say, hey, give them oxygen at the advanced levels, give them some IV fluids or some pain medications, but do not ventilate them, do not put airways in them, do not shock them or do CPR on them. So it helps, and it's becoming a larger and larger push, so hopefully we'll see more of that. And then they'll obviously have special emotional needs. We talked way back when in the beginning of this course about the stages of death and dying. And the stages of death and dying, those people will go through that as well when they are in a terminal illness situation, and the family as well. Obesity. Obesity becomes an enormous issue for us. It's just getting worse and worse and worse all the time for Americans particularly, but we're a sedentary society that likes to eat crap, and there's a guaranteed, almost guaranteed weight loss plan. It's called Shut Your Mouth and Get Up Off Your Butt, but it's very difficult. There are certainly people who have medical conditions that attribute to this, but anybody who really truly wants to put their mind to it, now granted they may need the consultation of physicians, and sometimes they need some boost, but in general, the biggest problem related to most obesities is just simply our lifestyle. So allowing people to become comfortable when they're an obese patient is often getting them into a position that they can breathe in. And in most cases that's sitting up, and a lot of times with a fan blowing on them. So we also have to have special measures. Most of our cots or ambulance cots that we use are rated at around 600 pounds. Some of them a little more. The bariatric cots that are now out in many cases will take around 800 or so pounds in the upright position and up to 1,600 pounds if you put them all the way down and roll them. So sadly though, most of the motorized or the power cots do not have bariatric capabilities because of the extreme weight. So, and then of course having enough help is going to be critical. So this might be calling out extra sets of hands. dispatching an engine company or having whoever you can get come and assist, because it has the potential to be a difficult situation. The largest patient I've ever taken care of was 848 pounds. That's pretty radical, and it takes a lot of people to move 848 pounds. So obesity, of course, just destroys other body systems and makes it very difficult for them to maintain a healthy lifestyle. Usually hypertension, diabetes are very common, amongst others. The definition for obesity, though, you can take a look at in your textbook. It talks about their body mass index, and how you can calculate out the category of obesity. Bariatrics, the term bariatrics is used by medicine to refer to those dealing with the prevention and treatment of obesity. We have the homelessness and poverty. This is probably one of the most overlooked and under considered health problem areas that we have. We have a lot of serious health problems related to homelessness and poverty, many of those being mental health. Mental health can be a huge, and substance abuse is probably the second one, so if not tied together. The homeless also, of course, struggle with malnutrition, run high risk for other types of environmental emergencies. Occasionally they also run into some of these other health problems, such as permanent diseases and infectious diseases, for that matter. So homelessness is a major problem. There are homeless shelters, but there's not nearly enough shelters for the people that are out there. So autism affects 1 in 91 children, and it affects their ability to communicate. In many cases, it's not just the communication, it's the social skills that go along with it. It's not that patients with autism are necessarily cognitively disabled, because many of them actually do very well in school. They understand many of these more complex and abstract concepts, but the biggest problem with autism tends to be their ability to have interpersonal relations, and that may include an appropriate presence in public. So sometimes they're going to have outbursts of certain types of behaviors. Now, a lot of these things that we're talking about, we're really speaking in generalities, because there's a lot of different types. So we have to kind of be careful when we talk about that. But on 954 in your text, it does start to speak about autism spectrum disorders, and this is a very large, wide range of issues that patients fall into this. So they may have extremely high functioning, they may be fairly low functioning, so there's more to it. So some of the ABCs of dealing with an autistic patient. First of all, this course alone should not be your sole source of information for really any medical emergency or medical problem, but particularly with autism. There's a number of places around the state that offer an autism for EMS course, and you should try to look into those and see if you can get more information. But some things to keep in mind: the awareness, basic, calm, and safe. So it's very important for people to be aware of autistic people. They're very susceptible to the same medical emergencies and traumatic emergencies that the general population gets, but communication continues to be the challenge. So sometimes the autistic patient just completely clams up and goes into a shell. Sometimes they'll have some striking out. And some of them will not speak even at all. So it's not that they're not speaking to you, it's that they've stopped speaking completely. So They can have escalations and meltdowns, which become very, very severe, where you have temper tantrum-like activities, screaming and swearing, throwing, kicking, whatnot. Having a resource in your local community that understands autism can be life-saving, because a lot of times they will be able to provide you with specific keys and clues of how to deal with specific autistic patients that are in your community. So some of them have a specific type of flavor or a candy or something that they find very soothing that you can use. Basic. Keep your instructions very basic. They do not understand sarcasm. They do not understand euphemism. So you need to remain as clear and very, very basic. So you may need to say, like they mentioned in the book on 954, sit down here and point at a chair. Not, why don't you have a seat? They don't comprehend that. But if you tell them, sit down right here, they can generally track that and follow that. So ask basic questions. Sometimes we have to do what we don't want to, which is the short-ended or the short closed-ended questions, simply because that's all that they have the ability to answer. Basic means less stuff. So try to remove as many people from the room, as much extra stuff from the room, because autistic people can become very hyper aware. They can be in stimulation overload, sensory overload. So those sorts of things the less you have going on in there, the better. And then keep your treatments basic. This is persons with autism, they don't adapt well to change. We may need to do just as little as possible to get this person treated. Oxygen may not be happening. They may not want anything on their face. So, and then just be careful and talk to them. Ask them, can I put this up on your face? It won't hurt. So remember, they don't often understand everything that's going on, so just be careful. Be calm. When dealing with a person with autism, you have to have that calm affect. You have to even telling them to calm down really can actually have the exact opposite effect and cause them to go off. So force, aggression, those sorts of things, that's not going to help you. All that is, even though they do mention show of force can be an effective deterrent, being firm in your stance is one thing, but being aggressive is another thing, and it may invite them to show force back. So be very cautious. Take extra time, a lot of time. Sometimes this is just like a lot of our behavioral emergencies. We end up spending quite a bit of time on scene with patients with autism. And safety. So having a sense of safety and security is important to patients with autism. They may have certain, again, like I said, smells, sights, tastes that make them kind of go into a little comfort zone. And so trying to keep them, protecting your own safety and keeping them safe as well. So you have to take it very, very basic and very, very slow, step at a time. So here's your autism video. Okay, so some advanced medical devices found around the home. There's lots of equipment in the homes now that was never dreamed of being in the homes just even years ago. And we can even look at our own profession for examples of this, where we might be talking defibrillators. 50 years ago, to use a defibrillator, you had to be a doctor. only doctors use defibrillators. Now we put little tiny defibrillators inside people to just do their own thing. So that's a good example of how things have changed over the years. First rolled down to paramedics, and then we taught EMTs how to use a defibrillator, and then the automated ones came around. So there's been huge advances, and machines have gotten smaller thanks to technology as well. So your caregivers, usually people who are around the home or are at home with these technology and these different medical devices, will have also caregivers assisting, because in many cases the patient can't strictly run this all themselves. So use them to your advantage. You may not think that they have a whole lot of knowledge in emergency care, and they may not have specific knowledge in emergency care, but they probably know way more about this device and this patient's condition than you ever will. So use them to your advantage. Don't brush them away. So they usually get some significant training. Ask them if they've ever had problems and what have they done to fix it. Have they been taught how to fix the problem? Have they tried to fix it, and what did they do? And then obviously, how do you normally move the patient? So take, for example, if you go back to, say, the patient, well, in this picture, that patient's actually on a home ventilator. It's a very, very small transport ventilator, but that patient's on a home ventilator. How are we normally going to transport this person? This could be with that transport ventilator, or maybe you just have to do what's simple and within your scope of practice is take them off the ventilator and bag them. You have a bag valve mask. You can use that. Take the mask off, hook it up to their trach, and away you go. So here we're also seeing a lot of equipment here. This person's got a tracheostomy, and again, that transport ventilator positioned over there. So talk to the patients. A lot of times the patients even have good abilities to assist us. So we can talk with the patients and find out, what do we know? What do they know? Compare notes. And then, of course, anytime we're caring for the patient, say we take that patient off the ventilator and we decide to transport her by bagging her. Ask her, are you getting enough air? Do you feel like the breath is big enough? Do you feel like you need more oxygen? And do you have any pain? I mean, all these sorts of things help us to tailor what we're doing to meet that patient's needs. So, EMT Assessment and Transport. So we often have to, of course, know what our protocols allow. What can we do? What can we not do? If you have a patient, let's say, that's on the home ventilator and is going to be transported in, and you cannot take somebody along that knows that ventilator and can run that ventilator, you probably need to remove that patient from the ventilator and do an alternative, ventilate the patient. Because if something goes wrong with that ventilator on the way in and that patient dies, you are going to be responsible. So we need to do something that we know how to do, something that we have control over. So knowing the protocols, and hopefully if you have a proactive medical community, they will let you know sometimes when you have people coming home to the community. They may suggest to the patient that they call and let you know, hey, we have a patient here at home who has a home ventilator. We wanted you to be aware, and maybe we'll even work with you to kind of work on some plans should something happen. So other things to kind of look for if we have a device issue. If we have a device issue, is there a problem with the device that's life-threatening? So the patient doesn't get a decent breath from their ventilator. Take them off. That's an easy fix. Do you have the knowledge to fix this? Do you have the supplies to fix it? And do you have any protocols or medical control authorization to do anything about this? A lot of times it's turn it off or put it on pause, transport in, and then we'll let the doctor and nurses and whatnot deal with the situation. So here's some think about it. It's about dealing with an autistic child who's escalating, and then what would be most important questions to ask you if there was a medical device failure. So let's talk about some diseases and conditions. First of all, we have two different major categories of diseases, both congenital and acquired. The congenital diseases are those that the patient is born with. So you can have congenital heart diseases. Heart disease in kids is rarely a result of something they have done in their lifetime. Once you hit 40, heart disease is a result of things you did stupidly for the last 40 years. But, 4-year-old kids don't have bad hearts from what they've done. They have bad hearts from the beginning. So it was a congenital thing. Cleft palate, where you have an opening in the roof of your mouth. A lot of times it also affects your lip. And the cleft palate is often an airway, potential airway issue. You can have congenital deafness. You may have people who are born with problems with their musculoskeletal system. You may also have acquired problems such as COPD, AIDS, traumatic spinal cord injury. You can have deafness from other issues. So some of our special concerns, patients with chronic disease may experience a sudden worsening of a disease. There are a lot of people who go home on home care, and we rarely see them. And that's actually a great thing. It means that the system is working. Home health is working. But then again, we have those people who go home on home care, and once a week they're back in the hospital. Obviously, we're kind of missing the boat on those people. People can become acutely ill as opposed to their chronic disease. So let's say we have a patient who's on a chronic patient with renal failure. Eventually they may go from having something called peritoneal dialysis, where they kind of get their dialysis at home, and shifting to needing hemodialysis, where they have to go to usually specific centers and have that done. We may also have somebody who has the, let's say, renal failure, and all of a sudden now they come down with a pneumonia. So it's a completely different area. Maybe it's a severe kidney infection that is related, but it really wipes them out and takes out a lot of their abilities. So to talk about a few advanced medical devices, respiratory-wise, people on CPAP. CPAP is something we have briefly brushed on throughout the course and how this works. It is something that you can have additional training as an EMT to do. CPAP, many people are familiar with CPAP. For those people who are have sleep apnea, like myself, it's where you basically put a mask on at night, either over your nose or your face, and turn on your machine, and it just constantly blows air into your respiratory tract. And it helps splint your airways open. If you didn't know what CPAP stood for, there it is right there, continuous positive airway pressure. If you want to experience CPAP and don't have access to one, you can basically get the same effect. Get in your car, and hopefully somebody else is driving while you do this. Roll down the window, drive down the interstate with your head out the window, and try to breathe. It makes it a little bit more difficult to breathe because you got all this air blowing at you. You get the same sort of effect. Anybody who's put on an air pack for a fire department has experienced something similar. Not quite the same, but it's close. Tracheostomy tubes. Trach tubes are tubes that get obviously put into people's throats for them to be able to breathe. Both the CPAP and the trach tubes, or tracheostomies, can be seen on page 960 in your textbook. The CPAPs are just showing the nasal masks. They're not showing the full face masks. But and then the tracheostomy tubes, as shown in the little guy on the bottom there, It's just an opening that creates a shorter route for air to get into the lungs. And then, of course, home ventilators. Ventilators are devices, obviously, that breathe for the patient. There's all different shapes, sizes, types. They do different things. Some of the ventilators do CPAP or a type of CPAP on top of being a ventilator. Some of them are itty-bitty tiny. Some of them are huge. So we've got a vent circuit that goes to it. You saw several examples in preceding pages of people who are on ventilators. Although a lot of patients are dependent on their ventilator for breathing, some can still live a fairly decent life. Some people are only on ventilators at night. Some people have certain types of valves installed in their ventilator system that will allow them to talk while they are basically exhaling. So we may get called for a lot of things. The ventilator quits, the ventilator goes haywire, the patient gets an infection to around their trach, they have their tracheostomy comes out and they can't be ventilated that way. So there's lots of different things that can potentially bleeding occasionally. So again, worst case scenario with that home ventilator, we get out the bag valve mask. If we can, if it's a problem maybe with the trach, we can take the bag valve mask and we can actually try to ventilate them the normal way. Now, if that's the way you're going to put this mask over their mouth and nose and attempt to ventilate them, you may need to cover their stoma or their tracheostomy so air doesn't blow out. You can attempt this. It may not always work. Other situations, you may take like an infant-size mask, hook it up on your adult BVM, and then put it right over the trach or the stoma. Well, if it's a trach, you should be able to hook the bag directly to the trach. If they have a stoma, which is just the opening without that appliance, you can try to ventilate them that way. There's an example of a full-face CPAP right there. A lot of problems are really not usually machine-based. You probably want to bring the machine with you to the hospital if you can, because the hospital may want to use it. They may not have something readily available. And then obviously alerting the ER staff is important, but making sure also that they're aware that this is not their standard run-of-the-mill patient, so they may need to get some extra hands or equipment ready. So we talked tracheostomy tube again. The tracheostomy tube is that opening in the neck, which is the stoma, and then there's a tube that goes into that. That is what the bag or the ventilator hooks to. And one of the big problems with trach tubes is they get a mucus buildup in there, and the patient may or may not be able to speak, like I said earlier. So if you've got a tube that's potentially clogged, you can use your whistle tip catheter and then just suction right there where you can basically see. The patient may not like this. It usually causes them to have kind of a coughing spell. That's normal. Ventilation, of course. And then if the patient's having issues, elevating their head can help with drainage and whatnot. Why do we keep going back to home ventilators? Cardiac devices. So implanted pacemakers, AICDs, or automated implanted cardiac defibrillators, left ventricular assist devices. The first two, there's not a lot for us to do there. There's tons of people with pacemakers. There's a lot of people who also have AICDs. Some of them have a combination of both. So the big potential issues that pop up here are usually a battery issue. Occasionally it's a wire issue, where the wire that actually connects it to the heart becomes a problem. These have to be switched out every so many years to maintain a fresh working device. Batteries, they don't plug themselves in at night. The batteries are intended to be long running, and In many cases, you will see pacemakers placed high up on the left chest, so basically right almost between under the collarbone on the left side is where you typically see pacemakers. AICDs, though, are usually a little larger, and those are many times placed in the abdomen. One of the things that you will hear sometimes, patients are getting shocked by their AICD, and it hurts. It really does hurt. It may be going off and going off and going off. And these things can have malfunctions. They can just start going off and not actually be necessary that they're shocking the patient. So if that's the case, try to calm your patient the best you can. And if you can get ALS, of course, that would be probably a good idea. And then just get them transported in. Understanding these people, they say it feels like getting kicked in the chest by a horse. So now the left ventricular assist device, the LVAD, this is a completely different concept. You can see a nice picture of this on page 964 in your text. This picture's got the pacemaker where it may be placed. There you go. It's also had open heart surgery. You can see the scar down his chest. The AICD we talked about. You can do CPR and use an AED on patients with pacers and AICDs. And then we have this gentleman here with the left ventricular assist device. That LVAD, he has to wear that kind of vesty looking thing, and he's holding a battery unit there, and the actual pump itself is down there on his belt. He usually has 2 batteries. There's probably another battery tucked in one of the pockets on his vest backpacky thing. What this device does is it actually does go into his chest it goes right through his chest or abdomen wall, and it pumps blood through his body through a screw pump device. So in reality, if we were able to get a pulse on this gentleman, he does not have a pulse, he does not have a blood pressure, but if we were able to get a pulse on him, he would have a pulse several hundred times per minute. The way that this device runs, just constantly is just moving blood, moving blood, moving blood. It doesn't allow it to build up and then press it, build up and then press it. It's just in constant circulation and motion. Often patients will be on a left ventricular assist device if they have, if they're on a heart transplant list, they're waiting for a heart. One of the big things is you cannot, besides they don't have a pulse, but if this person is unresponsive and obviously has no pulse, you cannot do chest compressions on them. Do not do chest compressions on a patient with an LVAD. If you do chest compressions on there, you will actually rip it out, and then the blood will basically just pool in their chest. So CPR is out. They usually have these battery packs, and then when they're at home at night sleeping, they're plugged into a different type of battery. It's actually kind of a charging unit more or less, but or a constant power unit that supplies this so they don't have to run off a battery. They always have the 2 batteries, and then they usually will have another spare battery or 2, and they almost always have a spare pump on them. So there is a group of people who will come out and do classes on LVADs for you. If you're in the Omaha metro area, whether you're in Iowa or Nebraska, these people will go out and do a class for you on left ventricular assist devices. Contact the medical center, Nebraska Med Center. They can get you in contact with these folks. And if you have a person in your community that has an LVAD, very, very beneficial. This is so cool. And just to check this whole system out is just awesome. So there is a rescue pump that should the whole device quit, you can manually pump it. But again, like I said, most of the time they have even a second little pump with them that can be plugged in a moment's notice. And very, very neat device. I hope you get an opportunity to check one out. make sure you have the electric source, make sure you have the pump if they have it available, and then the battery should be secured so it doesn't pull on the tubing. Tugging on that tubing, the specific tubing that comes out and goes into the chest, can create some errors. So some gastrointestinal, gastrourinary devices. We may have things such as feeding tubes, urinary catheters, or ostomy bags. You can see two of the three of these, I guess, on page 965. Feeding tubes, urinary catheters. There's a feeding tube. This little guy actually has a feed. He has what's called a G button, where that tubing does not normally stay attached there. He's got a little flip cap in his abdomen wall where mom can plug in that tubing and then give him his feeding that way. In many cases, it's somebody who can't take nutrition through the normal route, through mouth and the stomach and whatnot. Here's another example of a feeding tube. This one is actually a feeding tube. This baby's also on a ventilator, but and trached. But this one's just got a little bigger disc on the outside to help us pay attention to it, and same sort of thing. So if we have a patient with a feeding tube, usually we are going to ask the parent or the caregiver to stop the feed. Some people are on constant feed, and others are just periodic feed. So if we have a feed infusion going, we may ask the parents for the duration of transport, it would be best to shut this off if we can, flush and cap it, and then once we get back to the hospital, we can resume this. If you have to take it and it's going, make sure you keep that nutrient bag higher than the tube, just because gravity will keep the content within the gut as opposed to spilling it back into the bag. And then, of course, there's usually a protective cap that goes on. It's usually attached. Urinary catheter. This is an absolutely terrible picture, but probably a better picture in the textbook on 965. But urinary catheter is where you have a drainage tube that comes out of your urethra and spills into a bag. A lot of times when people don't have the ability to the sphincter tone in order to retain their urine for a specific amount of time before they go and let it out, will end up with urinary catheters. Others, people who are bed confined. Now here's that picture as well. So good example of how we find them. In most cases, this is not an emergency, but it can be very helpful for you to see the color of the urine in the bag, see if it looks like normal pee, or does it look like pea soup? Is there a lot of stuff floating in there? Maybe it's full of blood. So if you have a bag that's getting full prior to transport, it would be a good idea to have somebody empty that. Hopefully the caregivers around would empty it for you, and then document how much had been emptied. You may even inquire over how long of a period of time was this. And those have to remain lower than the patient's bladder in order for them to drain. An ostomy bag, this is actually somebody's colon is dumping into a bag. It's usually not immediately visible through the clothing unless you can see that maybe tight clothing and there's a poofy spot there. Big problems. They talk about infection at the stoma site, blockage, and dislodgement. The biggest problem is it leaks. You get leakage all over the place. So if you get this, get a patient with this, you're going to need to talk with the caregivers a bit. There has to be kind of a sticky, they call it a wafer, that goes in between the skin and the bag that helps basically secure it so they can continue to pass their stool into the bag. Their stool is not normal and formed in most cases. It's usually very liquid. And if you break one of these bags open on you, you'll wish you hadn't. So, patients with dialysis. Dialysis is a procedure where patients with kidney failure have their blood filtered by a couple of different methods, whether it's hemo or peritoneal dialysis. Hemodialysis is when they actually will take their blood out, spin it through a big machine, pretty stinking big machine in most cases. And the membranes and the solutions that are put into the machine do the filtering of the blood, and this takes normally around 3 to 4 hours, where these membranes will slowly start pulling toxins out and the blood goes back in. Usually the blood's in and out, in and out, in and out a few times, and it just gradually starts to drop the toxins that are in the blood. They usually will go to this about 3 times a week. Peritoneal dialysis, on the other hand, these people usually have dialysis almost every day. However, they can do it around the house. A lot of times they'll do it when they're sleeping, where they actually will they'll take a bag and fill up their abdomen in between all their guts, fill it up with a specific solution, let the solution stay in there for a little while, and then the solution starts to draw the toxins out. And then after a while, after it's had opportunity to pull some of those toxins out, then they will change the bag and allow for it all to drain out. This usually takes quite some time, and these people, they can live a fairly decent normal life at home, but that's peritoneal dialysis. A lot of people that have peritoneal dialysis eventually end up on hemodialysis, but the common problems that we have with dialysis patients include having bleeding from their site, and their AV fistula site is kind of a really big vessel with a bridge in between the artery and the vein. Peritoneal dialysis, sometimes their catheter becomes dislodged, and another big one is they get infection. A lot of times they'll get an infection which is called peritonitis because they're usually not as diligent about being clean at home. They can introduce bacteria then into the gut when they're trying to do dialysis. These people can become very, very sick. So assessment, don't take the blood pressure in any arm with a shunt graft or fistula because you can cause major issues with blood flow and causing some damage to that shunt. The rupture of a shunt or fistula is going to cause a significant amount of blood loss. You may need to be ready to have somebody do nothing but hold pressure on that, and a tourniquet is not absolutely out of the question. Treating them for shock. A lot of times when people come off of hemodialysis, they're very tired, they're very weak. Another big issue with people with dialysis, a lot of times they're diabetic and they become hypoglycemic. So some central IV catheters. A central IV catheter is when people go home with IVs, whether they're getting their nutrition that way, chemotherapy, pain meds. You can have all kinds of different catheters. You can have the peripherally inserted central catheter, which is a PICC line. You hear about PICC lines quite a bit. Those are usually in their arms, in their antecubital fossa, which is where you bend your elbow. And then they may also have another type of central venous line, whether it's a Hickman or Groshong, a Broviac, Swan-Ganz. I mean, there's all kinds. People aren't going to go home on Swan-Ganz, but there's all kinds of different names for these things. They may also have a port, just an implanted port that's simply underneath the skin, and they get their access that way. It's a lot quicker than having to dig around for an IV in the field at the paramedic level, and it's obviously a lot easier for them in the hospital when they're getting lots of either blood drawn or fluids and medications. You can get complications. Biggest complications tend to be infections at the site. Occasionally, you might also get asked to come because they suspect that there's a blockage. Not much we're going to do for that, but transport them in. Do not tug on this device. Be very careful with what you're dealing with. Don't be removing lots of dressing because you run the risk of catching that. A lot of times they're taped down very well so they don't get tugged. We may have patients with specific physical impairments, whether they're deaf or they're blind, they're mute. Obviously, we have those that have musculoskeletal issues that don't allow them to do the standard locomotion. Obviously, you're going to have to approach each patient differently here. Some of these are a little easier to deal with than others. If you have a person that's simply mute, in many cases they can write. Deaf patients in many cases are obviously able to read, so you have other ways to communicate there. Physical impairment doesn't mean mental impairment. So be careful in the way that you address these people and you speak to them initially. Yes, you might be right. Yes, they may have a mental impairment on top of it, but in many cases it's simply a physical issue. I mean, we'll take a great example. You know, the renowned physicist Stephen Hawking's brilliant mind, but just to look at him and the way he's all disformed and disfigured and wadded up in a wheelchair, people would a lot of times assume, oh, well, you know, there's nothing there. Oh, contraire, one of the most brilliant minds ever. So, so an impairment can be come in lots of different forms. So you're just going to have to assess the impairment, look at their baseline, what's new, talk to the family members, say how are they normally, what can they normally do, and now what do we have. Try to determine how comfortable they are. Bring specific aids with them. So if there's hearing aids, if there's glasses, if there's, you know, a specific electronic device that helps them communicate, crutches, wheelchairs, walkers. Wheelchairs are not always easy to transport in any ambulance, but most of those other items can be readily transported. And the final part of this chapter we need to talk about is just briefly on abuse and neglect. We obviously have, and we've kind of touched on this in the past, but people who are vulnerable are those that are dependent on others. Whether we're talking about patients who are children, maybe it's dependent adults, they have permanent disabilities and whatnot. Sexual abuse certainly occurs a lot, both in the elderly population, the mentally disabled population, and children. It can be adults or children. Spousal abuse, of course. But the chronically ill elderly get often taken advantage of as well. So things that you need to look for: stories that are inconsistent with the injuries, injuries in multiple stages of healing. I think we've talked about that in the past. You know, kids are going to fall down. They're going to get bruises on their knees and their elbows. They don't usually get bruises on the backs of their thighs or the middle of their back. Those are a little harder for them to fall down and do for just doing kid things. Repeated injuries, and then the caregiver either being indifferent to whatever's going on, or sometimes it's just over the top, ridiculously dramatic about the situation. Any of these one things alone don't necessarily mean anything. However, when you're looking at more and more info, when you're getting more and more info out of these people, that helps to build the case, build the story. Things to remember: do not make accusations. The best thing for us to do is get the patient out of the environment. So if we start getting mad, if we start saying things, if we start making insinuations, oftentimes the caregivers or the abusers are going to catch on, and then in those cases the patient, they may say, no, you can't take the patient now. So it's best for us to do what we can to get them out of the situation, and then hang all kinds of paper on this. Make verbal reports, make written reports, get law enforcement involved, make sure that the doctors and nurses are well aware of what's going on, and then hopefully we get the different social services involved to help and rectify this situation. So how does your approach in cases of possible abuse or neglect differ from your approach in other cases? Sometimes we're being more sneaky. You know, we suspect it. And you know, if we're dealing with a medical patient or trauma patient, we may be much more open about what we're suspecting. Whereas in an abuse case, we were probably going to play it up a little bit and say, oh yeah, okay, so you fell, and we're just trying to be looking out for the best interest of getting that patient out of the environment. So our chapter review: patients with special challenges include those that are homeless, living in poverty, obese, sensory impairment, terminally ill, technologically dependent, developmentally disabled. Disabilities are conditions that interfere with their ability to engage in activities of daily living. The homeless, the poor, and the obese are at a increased risk for health problems, of course. Do not assume that a particular patient with special challenges requires EMS for problems related. Sometimes we're there really as a moral support. Sometimes the caregivers get a little upset, freaked out. Of course, be empathetic and respectful. Use the ABCs system for dealing with the autistic. Use your resources to the best of your advantage. So if you've got people that are experts in that type of care and that type of equipment, use them. Do not disregard them. Remember that assistive equipment and special accommodations are now allowing a lot of people to have a fairly normal life. Don't leave these behind, because these people need these things. Overstimulation of a patient with autism can cause actually bigger issues. To ensure proper care, you got to recognize, understand, and evaluate the patient's healthcare challenges. Caregivers and patients can provide valuable information on special health challenges and advanced medical devices. Chronic diseases or medical conditions may present as the primary problem or may complicate another illness or injury. Kind of like our sick person that crashes their car and becomes now a trauma, so they're both a medical and a trauma patient. When encountering advanced medical device, consider what the device is doing for the patient and how important is it for the patient's survival. And then with the help of the caregiver, get that transported, discontinued, what have you. Special health challenges often make patients more vulnerable to abuse and neglect. All right, so the questions for you to consider: what does the ABC stand for the autistic child? What does the CPAP do? Can a responder be injured by an AICD that discharges? So your critical thinking question is: you're called to transport a ventilator patient. As you begin your survey, the ventilator stops functioning. What steps do you take to care for this patient? What transport considerations do you have? Well, we have a backup ventilator in all of our trucks. It's called the bag valve mask. So we get out our bag mask, we take the mask, we toss that off to the side, we unhook the ventilator, we start to ventilate the patient by hooking the bag up to their tracheostomy, and that's the quick fix. And if there's a backup ventilator somewhere that the caregiver can assist in getting, that may be appropriate, or maybe since we're already bagging them, that's just the best way to transport and handle this person. Transport considerations: obviously if you have to transport a ventilator, you're going to have some needs to where are you going to place it, how are we going to power it, what are we going to hook it up to. Also, we need to let the ER know ahead of time. We're bringing in patients typically ventilator dependent. You may want to get some more hands-on and some equipment down there.